Please put them in the Q&A and we can get them later. I do want to share the screen that the slide that I thought I was talking through before. So that was James Brooks, who is phenomenal. And you all heard that. So we're moving right on now to racial and ethnic differences and disparities in breast cancer. Allison Kurian, Associate Professor of Medicine and of Epidemiology and Population Health. So with that, we'll pass the baton to the other side, the other top incident cancer, but in women.
Great. Well, thank you so much, Marcia. Can everyone hear me okay?
Yes.
Very good. I will share my screen now.
Thank you, Jim. That was great.
It really was. Can everyone see my screen okay?
Yes, but it looks like it's off. It's a little wide.
This is where things get a little bit...
Looks fine on my screen.
Chat.
It's okay on your screen, Jim?
Yeah.
All right, maybe I'll go ahead and we'll see how things go. Let me know if anyone else has difficulties. So very glad to be invited here. Thank you so much for the privilege of speaking to this group at this exciting meeting. And I'm thrilled that I got to hear Dr. Brooks talk because first of all, it was excellent. And second of all, it turns out there are many parallels to what I'm going to talk about in terms of breast cancer and prostate cancer and thinking about challenges that we have in these two fields. So the topics I want to be sure that I covered today are for us to think a bit about breast cancer as an informative tracer condition. I want us to talk about breast cancer incidence and mortality by race and about disparities in screening and treatment. I also am going to talk a bit about ongoing research and future goals. Let's see if I can. Very good. So in terms of causes of death in the United States, you may have heard other comments about things like this in other talks today. But at any rate, what we see over the last several decades here is the history of what's happened with chronic and acute causes of death in the United States. And we see that there has been quite a bit of decline in cardiovascular diseases, deaths from diseases of the heart, from cerebrovascular diseases. And what that's really left is a fairly steady line here for deaths from malignant neoplasms, as you see. And sometimes you'll hear patients say, well, cancer is getting more common, or deaths from cancer are getting more common. Often it really is that the other things are better controlled and we live longer. So at any rate, we know that cancer is an important cause of death in the United States, that 1 in 2 to 1 in 3 adults are expected to develop cancer in their lifetimes, and that we do see similar trends in developed and increasingly also in developing countries. So I said that I see breast cancer as an important tracer condition. This is the most common cancer of United States women. You see the parallel again to Dr. Brooks's comment about prostate cancer in men. The lifetime risk of breast cancer in United States women is around 1 in 8 or 12.5%. And this is a cancer for which the incidence has risen, but mortality has fallen since the 1970s for some similar reasons that you heard about with prostate cancer. In breast cancer, we have screening with mammography, which is an X-ray of the breasts. That is early detection, and it is quite effective in reducing mortality. We also have advances in treatment, both in terms of anti-hormonal therapy or endocrine therapy and in terms of chemotherapy. This is a disease for which there are well-defined genetic causes as well as reproductive, environmental, lifestyle causes. And I think it's an interesting topic as a lens through which we can understand and address some of the health disparities, both in oncology and more broadly in medicine. So this is a figure that I think can be helpful as we try to get our hands around these questions of incidence and mortality in cancer. This is a map of the world provided by the International Agency for Research on Cancer in 2018, the World Health Organization. And here what you're looking at is darker colors are age-standardized incidence rates of breast cancer that are higher. So the darkest blue, highest rates. The lightest blue, lowest rates. And you can see here what many of you may already know, which is that breast cancer tends to be a disease of developed countries primarily, or at least in recent decades, that's been the case. We see North America, we see Europe, we see Australia really highlighted here in terms of incidence. But the important thing to think about when you think about breast cancer, going to the next slide here, is that the burden of mortality is not necessarily the same as the burden of incidence. And again, this is a disparities issue. Once again, in this figure, the darker color means higher age standardized mortality rates, the lighter color lower. And you see that these countries that had the highest incidence rates, United States, Australia, Western Europe, are not the ones with the darkest colors in terms of mortality. We see some of that in Africa. We see some of that in parts of South Asia. So this is, again, a different picture in terms of who's getting the cancer versus who's dying from it. So what do we know about risk factors for developing breast cancer? This is a table that shows relative risk factors for breast cancer by descending order of risk. So factors that are really strong, that multiply the average risk by 4-fold or higher, include age. So the risk of developing breast cancer increases up until age 80. I should have put sex. This is certainly a cancer that is far more common in women than in men. It does happen in men, but is much rarer and has different risk factors. In women, we see a strong personal or family history as being quite important. Often that is a proxy for a high-risk gene mutation like BRCA1 or BRCA2. We can also see premalignant lesions that may come up on a biopsy, things like carcinoma in situ or atypical hyperplasia. We then can see moderate risk factors, things that approximately double to slightly higher than that, but less than 4-fold the average risk. These would include having one affected first-degree relative, having a moderate risk gene mutation with names like CHEK2 or ATM, not at the level of BRCA1 or BRCA2, but they do increase risk. The exposure of chest wall radiation, usually not just diagnostic like a chest X-ray, but therapeutic. So for example, treatment of a cancer like Hodgkin's disease at an early age, which includes radiation therapy to the chest in some cases, substantially increases risk. Another factor that I'll talk more about in a bit is density of breasts on mammogram. And that's something that is the way a breast looks on a mammogram, that it is sort of more white tissue instead of the usual gray appearance and harder to see a breast cancer on the mammogram. There's also some evidence for high postmenopausal estrogen levels. When we look at factors that increase risk a little bit, so not very much for any individual woman, but that are important across the population level, we can see that factors like early menarche or late menopause, late age at first pregnancy, no pregnancies or breastfeeding, recent use of hormone replacement therapy or oral contraceptives, so factors that change the hormonal milieu in ways that we still don't fully understand, but seem to have to do with longer or more lifetime estrogen exposure. We see a few other factors like postmenopausal obesity, alcohol consumption, oddly enough, greater height and higher socioeconomic status, which we don't know why, but people have waved hands about nutritional exposures during the adolescent years and questions like that. So again, many factors playing in. So we know that there are both environmental or reproductive lifestyle and also genetic factors that contribute to breast cancer risk. And as we think about racial ethnic disparities, I like to refer to some very classic studies in this field, which were of migrating populations or migrant studies. And so this is an old and rather fuzzy figure. I couldn't find a better looking one, my apologies. But from some very classic work back in 1993 from epidemiologists looking at breast cancer relative risks in Asian American women by history of coming to the West, coming to Hawaii and then California. And they looked in these women, Chinese, Filipina, and Japanese American women, they looked at the number of grandparents born in the West, Hawaii or California, versus in Asia. And they also looked at urban and rural location of these women and found that the lowest risks were among those who had all 4 grandparents in rural settings in Asia, with the highest risk being in those who had the majority of grandparents in the West. So clearly this is not genetic. This is a factor that has to do with exposures at various times of life that we're still working out, and just makes the point that exposures, lifestyle, reproductive factors are important in this disease. Well, what about genetics? I did mention that these genes like BRCA1 and 2, like ATM-CHEK2, these are genes that are inherited and normally have a role in DNA repair, that they are important in this disease. And when we think about race and ethnicity, it's important to note that the prevalence of inherited mutations in genes like BRCA1 and 2 are actually the same across racial ethnic groups. There is a slight blip of higher BRCA mutations among people of European Jewish ancestry, but accepting that subgroup, it's basically the same in all racial ethnic groups. So about 5 to 10% of breast cancer is related to these inherited gene mutations. While that's the case, we know that in fact there are significant disparities in access to genetic testing. That has to do with the cost of genetic testing, though this has been improving in recent years, and also inequities in referral for genetic testing by physicians. We see that there is less referral of certain racial ethnic groups, particularly Black and Latino women. And because of this, because there's been less testing among non-white groups, we actually have much less data on the natural spectrum of genetic variation in non-white populations. And because of that, we do see a higher rate of uncertain test results among non-white groups. And that is really not a biological issue, it's an access problem. But because of these uncertain results, there's some evidence that it may lead to misinterpretation and suboptimal treatment of these patients. So I'll talk a bit about breast cancer biologic subtypes and really just say that all breast cancer is not created equal. The most important markers in breast cancer are the estrogen and progesterone receptors, ER and PR. And I told you that there are a lot of hormonal factors that do play a role in risks of breast cancer. They also play a role in breast cancer treatment. And so this was a very classic paper from 2006 from the Carolina breast cancer study that looked at breast cancer outcomes in Black and white women. And here we saw some rather complicated tissue microarray data clustering of gene expression that divided breast cancers up into a favorable luminal group and a higher risk HER2 positive group and basal-like group. When we looked at our standard clinical measures, that really mapped to the good prognosis group was estrogen and progesterone receptor ER or PR positive and negative for this HER2 aggressiveness gene. The HER2 positive breast cancers in some cases did less well, but we are developing better therapies for them. And then there were the basal breast cancers, which in the clinic basically are triple negative. They don't express any of the targeted markers that we've developed drugs for. And thus, not surprisingly, it's been found that these ER/PR positive breast cancers or luminal breast cancers have best survival. The triple negative ones have the worst. So what does that mean across racial ethnic groups? Well, what it actually means, showing some work that we did together with colleagues whom Dr. Brooks previously mentioned, Scarlett Gomez and others at UCSF, using the State Cancer Registry, is that you can see there's quite a bit of difference in what kind of breast cancers people get across race ethnicity. If you look at the absolute risk of developing breast cancer among women in California, the risk is highest among white women at a 14% absolute risk, followed by Black women at 11%, Asian at 10%, and Hispanics at 9%. But when we look at the distribution of these good and bad subtypes, with the luminal or ER positive subtype being most favorable, we see that it is not a similar distribution across racial ethnic groups when you compare to the triple negative, which is worse. And so you can see that Black women have about double the incidence of triple negative breast cancer as every other group, correspondingly less of these more favorable luminal breast cancers. So in addition to access disparities, there is also a challenge here with what appears to be a difference in tumor biology. And so we have seen profound and persistent differences in breast cancer mortality by racial ethnic group. This is a figure from a recent study from the American Cancer Society and Seer Registries that looked at 5-year breast cancer specific survival rates by subtype and race ethnicity. This is that good subtype, luminal or hormone receptor positive. This is the worst one of triple negative. We do see a gradient of how people do, but even within them, we're seeing that non-Hispanic Black women in red, unfortunately, are doing worse in all these subtypes non-Hispanic white women generally doing better, the blue, and interestingly, Asian Pacific Islander women generally doing the best across the subtypes, which is another interesting racial ethnic difference. When we think about detecting cancer, and particularly breast cancer, a figure like this gives a very stark reason for why we might want to find it at an early stage when there isn't very much of it. And so this is a figure showing the 10-year relative survival by stage of breast cancer. Stage 0 is the earliest, which is non-invasive. Stage 1 is very small, less than 2 centimeters, no lymph nodes involved. Stage 4 is distant metastatic spread outside the breast. And it's pretty clear what happens when it presents late versus early. So that's been the rationale for mammographic screening, early detection by screening of asymptomatic women. And in terms of what we think about the contributions of screening and treatment to survival from breast cancer, this is a really nice study by our Stanford colleague Sylvia Plavritis and colleagues. And what they did was they looked at the change in breast cancer mortality in United States women from 1975 through 2011. This light blue line is what actually happened based on national data. And they used simulation modeling to estimate what the death rate would have been if we had not seen early detection by mammogram screening or improvements in treatment. And their estimate was this greenish gray line. So since breast cancer increased in incidence, if we hadn't gotten better at finding it early and treating it, mortality would also have been really high. But fortunately, due to advances in screening and treatment, it's actually down here. And they estimated that about half the benefit is from the addition of screening and about half or a bit more from treatment. So it gives you a sense that both of these things matter in thinking about cancer control across the population. So these are mortality trends in breast cancer over time by race and ethnicity. And what we can see is back in 1975, this was before mammographic screening began. You heard about Dr. Brooks saying that the PSA test really had an influence over prostate cancer during the time of his career. And I have to say that over the last several decades of breast cancer, mammographic screening has had a similar impact. So that started in the late 70s, early 80s. And so before then, you can see that Black and white women had really equivalent mortality from breast cancer. We see that as screening came along through here, we see again a change in mortality here in these cases, slowly going down into a decline in mortality. We see more case finding related to finding more cancers, but then a decline with mortality. Around 1990 is when treatments got good with breast cancer. So again, we're starting to see a drop, but still this gap between Black and white women, lower death rates and lower incidence rates among other racial ethnic groups. And so I think it's a few things. I think it's partly that non-Hispanic Black women have not benefited to the same degree from treatments. The most important reason, I think, is disparities of various different kinds. But here we also have this problem of the triple negative breast cancer that is more common among Black women and is harder to target because it doesn't express these markers, hormone receptors, and HER2 for which we've developed therapies over the years. So what about mammographic screening? We do see some disparities both in accessibility and in performance. This is an image from a paper where radiologists showed how they classify breast density on a mammogram. This first one is a non-dense breast. This is a side view of an X-ray of the breast or a mammogram. And this is what you want a mammogram to look like. It's gray in color and cancers show up white on mammogram. So it would be quite easy to see a white cancer on this mammogram. But as they get more and more dense, you see more and more white tissue on the mammogram, and it gets harder and harder to see a cancer. Oddly enough, extremely dense breast tissue is more common among Asians. We don't really know why, but we do see that. And so that can sometimes be a problem in terms of performance of mammogram and finding it earlier. The other challenge is that mammogram is not that good at finding rapidly growing aggressive cancers, which tend to pop up in between screening mammograms. And of course, those are the ones, the triple negative, that are more common among African American women. But of course, there's the bigger problem of access disparities. This is expensive. Insurance is needed, women need transportation, they may need time off from work, so it can be a double hit for some women in these racial ethnic groups, particularly Black women. In terms of disparities in treatment, there are a lot of challenges here. Again, the access disparities I mentioned, cost of oral therapies, insurance problems, but also challenges of comorbidities. Drugs like chemotherapy may be a problem for people if they have diabetes, heart disease, other diseases that are more common in certain racial ethnic groups. There are also problems of treatment delay, both starting treatment and completing treatment. This was a recent paper that showed treatment initiation delay by more than 60 days was highest in Black women over and under 50, and that prolonged duration, basically because it wasn't finishing on time, was also quite common in these groups. As we see other studies that have looked at the reasons for Black-white disparities in breast cancer mortality, there have been some interesting studies both in hormone receptor positive and negative breast cancer of trying to estimate factors like demographics, comorbidity, insurance, tumor characteristics, and treatment, and basically estimating the amount of differences in mortality that are attributable. So insurance seems to be a big deal. Tumor features are part of it. Comorbidity and treatment all play a role. Treatment looks like not very much here, but I think a lot of that is encapsulated in the demographics issue in these studies. So what can we do about it? Here again, we get into these healthcare system factors, and it was really interesting to hear Dr. Brooks talk about equal access healthcare systems like the VA and what happens with mortality. We actually tend to see some persistent disparities even in some military healthcare systems with breast cancer. Not always, but in some cases. Our group, together with, again, these collaborators that I mentioned, Scarlett Gomez and colleagues at UCSF, recently looked at hospital characteristics and found that women, particularly African-American women who were seen in NCI-designated cancer centers or American College of Surgeon program hospitals, which are known for being very methodical and making sure that things don't fall through the cracks, that Black women in particular had improved survival. Other groups did not when controlling for other factors, but Black women did. And so again, it may be that the groups that are most vulnerable to access disparities, to systemic racism, benefit the most from a very explicit program to mitigate these factors. And more needs to be done to explain exactly why this is true. But a number of other approaches to addressing disparities. Certainly mammogram outreach options like mobile delivery through vans and other options to try to make the test come to the patient and not the other way around. Patient navigators have been shown to be quite beneficial, either nurses or community health workers in Black and Latina communities in particular. There was a study that showed improved breast cancer survival at Harlem Hospital Center when navigators played a role, and that was certainly encouraging. And there have also been large trials looking at pragmatic quality improvement attempts like the ACCURE trial of reducing treatment delay for early stage cancer. So I'll just conclude with a number of important questions here. And I think there's still a lot of things we don't know. I mentioned that there is persistent worse survival of Black women with breast cancer in some equal access care systems. Why is that, and how can we fix that? It's interesting that there is better survival among some Asian subgroups and Latina subgroups, particularly foreign-born Latina women. So interesting to think about what that's about. And of course, most importantly, what specific interventions can actually improve disparities? The data we see about the American College of Surgeons is certainly interesting. Also, navigators, and then ways that we can focus on access and quality of screening and treatment. So I'll stop now and would be happy to take questions. Thank you.
So one question that came up, and you just alluded to it, is the Asian subgroups. Yes. So there's a lot of interest now in really looking at Indian and Japanese,
Absolutely.
Chinese, Korean, the census subgroups, but also the data that you showed lumps Asians and Pacific Islanders together, which we're just wondering if you have any data that separates these important subgroups.
We do, and that is great work led again by my colleague Scarlett Gomez, who has really been a pioneer in looking at this question. All Asian subgroups are absolutely not the same. Causes of death are quite different in South Asians versus East Asians, and even parsing out East Asian subgroups. So I think it's really interesting. Dr. Gomez actually has a new grant, a new NIH grant, to try to understand these differences, which I think will be compelling, and a lot to learn about why are the case and what the different factors are.
Thank you. And I'm not seeing other questions in the Q&A. So if anybody has a question, we still have Jim Brooks with us, and we have Allison Kurian. So this is your chance to ask about breast cancer and prostate cancer. And if we don't do that, I know that they're both very busy, so we can let them move on through their day. And I will share my screen and we can move on. But is there anything, last minute comments from either of you?
It's been a privilege, then. Thank you.
Our privilege. It's fantastic. Okay.